Okay, so today's lesson or lecture, is over venous access devices. We've already talked about peripheral. I'm briefly going to describe a midline to you, and then we're going to focus on central lines. All right, there are the three different types that we just talked about: the peripheral, the midline, and the central lines. Central lines may also be called CVAD. That stands for Central Venous Access Device. I think most people still refer to them as central lines, but I want you to know that terminology is out there. Many central line devices have particular specifications, so you want to make sure that you're following your policy regarding whatever the regulation is for that specific device. If you have a patient who has poor vein access or they need long-term therapy, then that's when we need to be considering central lines. Alright, so let's look at our peripheral just as a review here. Peripherals are our most common type. We use them for brief infusions. The length of the cannula is less than 3 inches. They're just a short cannula that's in there. We do use the peripheral veins. We rotate those according to policy, and right now best practice tells us that that's every 96 hours or every 4 days. We do not use peripherals for irritant drugs such as chemo, TPN, concentrated potassium, anything that would be considered an irritant drug. When you look at the midline, they are actually inserted peripherally, but they are inserted by sterile technique. We know whenever we just start an IV in someone's forearm, it's not a sterile technique. Remember, we just keep it's clean technique, or asepsis, as clean as we can possibly get it. The midline is a sterile insertion. It's inserted peripherally in the upper forearm usually. I believe that they usually try to use the basilic if at all possible. They are about 10 centimeters in length. The tip of it dwells just below the axillary level. So with the peripheral, again, it's not going to be that long, but with the central lines, they actually go further they actually end in the vena cava. So the midline stops right at the axillary or your armpit level. You can use those up to 6 weeks. And what you need to know about the midline is, as far as the insertion and the care of it, it's like a central line as far as the sterile procedure with it. But solutions that go through it are treated as if it is a peripheral. So it is not considered a central line, and you cannot put central line solutions through it, such as the chemo, the TPN, and the concentrated potassium. Okay, so our focus on the central lines. The tip of the catheter of a central line terminates in the central venous circulation. It's usually in the superior vena cava, just right above the right atrium. And then if you had a femoral line, it would be in the inferior vena cava. Okay, so all central lines, they require x-ray confirmation for positioning, and all of those lines have a radiopaque line or a tip on them, so they can be seen whenever x-ray is done. We don't routinely change out central lines like we do peripheral lines, and that's in order to reduce infection. It could actually pose a greater risk than if we actually left it in place if we were to change out central lines. Okay, and also something that you need to watch for with all central lines, and we're going to talk about 4 different ones today. All central lines give your patient a higher risk for cardiac arrhythmias, and think about that. Why would a central line have a higher risk for cardiac arrhythmias? So pause this and think about that for a second, and then come back. So I hope that you paused it and you come back, and I hope that your thought process went to this, that a central line ends where? It ends in the vena cava, right above your right atrium. Okay, sometimes that even slides down into the right atrium. So if I have that line so close to the heart, would it stand to reason that it could cause some interference and cause me to have arrhythmias? Okay, and one thing that you need to know is that all medications that can be given through a peripheral can be given through a central line, but not vice versa. So all medications should be able to go through a central line, but not all can go through a peripheral. Things that would be appropriate for central line. I've already said long-term course of antibiotics, chemos, TPN, PPN, vasopressor drugs, patients who are in critical care, surgery patients, emergent or trauma situations, and those types of central lines that we put in for emergent and trauma would be like a non-tunneled, and I'm going to tell you about non-tunneled in a bit. PICCs, ports, and tunneled are used for home or outpatient therapy a lot of times. So you'll see those. PICCs is your main outpatient. We usually use ports if we're bringing them in for like chemotherapy or outpatient treatment where they're coming in like that. So for outpatient therapy, what you will usually see are PICC and ports. Okay, central lines can have up to 4 lumens. Single, double, triple, quadruple. Look at the picture here on your screen and it shows you the end of a type of central line. And so when we tell you that they have different lumens, a lot of times students will look at this and see that they have 4 or 2 or 3 or whatever the case may be of IVs with coming out of the skin with like 4 different lines or 4 different ports. And that is true, but each one of those different lines goes to a different lumen in the tube. And I wanted to show you what the inside of a tube looks like. This is a double lumen, and can you see that the ports, you could have 4 different medications infusing if it was a quad, but with this double lumen you would infuse 2 different medications, and those 2 medications do not mix in the line itself. They don't touch each other. And actually this one is just like cut off flat, but the end tip of a central line only has 1 opening. If this were a double, the second opening would be somewhere up the shaft of that line, so that those medications never mix until after they have been in the bloodstream, so that they only mix with your blood. It's not a mixture before it hits the bloodstream. Hope that makes sense. Okay. The diameter will vary. It's going to depend on your catheter that you have. There's different lumens in the catheters. A distal, a proximal, and a medial, and usually that's what you're going to see is a triple lumen. Obviously, if you just have a double, you're going to have a distal and a proximal, and I'm pretty sure on those quadras you have a distal, proximal, and 2 medial. But what I want you to know about that is that for the distal lumen, we usually use that for hypertonic solutions, high volume, a little bit larger, it's a little bit thicker. For the proximal lumen, that's usually what they use for blood draws or administration if you need to. But usually they'll use the distal for blood administration. And then the medial lumen is what we give our medications through. Now, that being said, this is what they say these lumens should be used for. I'm going to tell you in a hospital setting when you go in there that each lumen could be used for different things, because say you have a double lumen but 1 lumen is clotted off, you're going to go ahead and use the other lumen for that purpose. Okay, types of central lines, the 4 that we're going to talk about. A PICC, and what does PICC stand for? Peripherally inserted central catheter. The second one is a non-tunneled percutaneous central venous catheter, and we'll just refer to that as a non-tunneled. And then you have a tunneled central venous catheter and an implanted port. And we're going to talk about each one of these individual. Okay, so the first one we're going to talk about is a PICC. PICCs are usually greater than 20 centimeters in length. Again, that's going to depend on your patient and their size and their need. It's inserted into a peripheral vein. We like to use the basilic, but you can use the brachial or cephalic, but again, the basilic is the one that we look at. The tip dwells in the lower 1/3 of the vena cava. Only a physician or a trained RN can put them in place, so you have to have trained licensed professional to put those in. They are sometimes done down in radiology as well, but the RNs down there or the physician down there will put those in. It's done under fluoroscopy or ultrasound, but it can be placed at the bedside, so you will see the physicians order and send them down or come into the units and actually put them on, so you may have to assist with this at one point. Again, x-ray verification has to be used. Single or multiple lumens. Usually a PICC has 1 or 2. It usually doesn't have more than that. And we usually use PICCs for home care, long-term IV antibiotic therapy if the patient has to go home for that, so that they don't have to stay in the hospital. We replace them only as needed, and we can use them up to 6 months. So we would only replace a PICC if the patient was done with the therapy and didn't need it anymore, or if the site became infected or something happened to the catheter itself. Okay, so advantages of PICC lines. They have less risk of complications. So because of where they're placed, think about this. Okay, they're placed where in the arm, versus some of these other lines that we're going to talk about in just a little bit that are put in the chest. So they have no pneumothorax or hemothorax risk because of where they're placed. Decreased risk for air emboli, and again, that's due to where they're placed. They also have a lower infection rate. So think about that for just a minute. Why would a PICC line have a lower risk of infection versus a central line that was placed in your neck or in your chest, or if you had a femoral line in your groin? So pause this, think about it, and come back and see if your thoughts were correct. Okay, so I hope that you paused this, and I hope that you thought about it, and what your brain went straight to is that it is actually related to the decreased number and type of microbes that's on the skin of the arm. So think about this. Think about the bend in your arm there, the axilla, or not the axilla, I'm sorry, around the AC area. That's kind of the area that we would start to go in, or up above that area just a little bit, right? So if we go into that area, think about that area versus your neckline, versus your groin if we went into the femoral. Can you see why there would be less risk of infection in that area of your body versus the other areas of your body? Also, an advantage would be it's more cost effective, and we've mentioned this before, that's good for home or outpatient IV therapy, and medications that we could use because it is considered a central line, TPN, chemotherapy, hyperosmolar solutions, irritants. So all of those medications that we couldn't put through the peripheral, we can put through a PICC, and all central lines, we could put those. Complications that we may see with the PICC, obviously bleeding. We just stuck you, so there's a complication of bleeding. You will see slight oozing a lot of times for about 24 hours, and that is considered normal. But if we're still seeing oozing beyond 24 hours, then we are concerned. Tendon or nerve damage, and how are we going to know this? By numbness, tingling, weakness that the patient may be experiencing. Malposition of the catheter. Okay, so we want to avoid any excess muscle contraction in that area that could lead to that catheter being dislodged or even occluded. Infection, we've already talked about that, but obviously there's a risk for infection there. And also thrombus or thrombosis formation. Now look at this picture here on your slide for just a second, and this is actually what we call a power PICC, and it's going to depend on the facility that you work at as to if you have these power PICCs or not, but this is what it will actually look like from the little hub there. That's the part from there back where the ports are, is what you would see hanging out of the patient, and then the long skinny line at the top of that picture is what it looks like in your patient. So with PICC maintenance, we want to do a dressing change after the first 24 hours, and then we would do it weekly and PRN if we needed to do so. We always use aseptic technique. Insertion and dressing changes for central lines, this includes PICC, and all central lines are a sterile procedure. So when we do the peripherals, it's not sterile, but central lines, when they are inserted, it is a sterile procedure, and the dressing changes are also sterile. Now, when you go in to push medications through those lines, that is not sterile. Okay, that's just you want to stay aseptic or as clean as you possibly can whenever you do that. Let's see. You may need to flush these with heparin, and you also want to make sure that you're avoiding blood pressure in the arm with the PICC in it. If you took a pressure and you had a PICC in there, you have a chance of damaging that PICC line. You could shear it off, and it could go floating wild in the person's bloodstream. So you want to make sure that you're watching that. All right, so what do we need to do as far as patient teaching? Well, we have to teach them about care at home because these people go home with a PICC line and they have to take care of it at home. So they've got to know how to flush it, and if a dressing occurs, or if like the corners of the dressing pulls up, then they have to know that they need to let the doctor or the physician know so that they can come out and change that for them. So we need to teach them the home care. We need to teach them when to notify the nurse or the provider or physician or whoever it is that they have to contact. We want to make sure that we emphasize with them that they have minimal activity with that arm. Again, we're looking at dislodgement here. And then also to protect the site when showering. And those of you who have seen IVs and patients who have them when they shower, you know that we wrap them because we don't want water pouring down on those sites. But they actually can bathe. We just have to protect that site and wrap it up. This picture on your slide here is what a PICC looks like in a patient's arm. That's what you will see if you go into a hospital and a patient has a PICC. That's exactly what it looks like. This is a double lumen. So okay, so let's move on to non-tunneled catheters. So non-tunnels, they're in there for around 3 to 10 days, and research actually says that you can use them up to 6 weeks, but definitely less than 6 weeks. I will tell you that if you have those in for more than 10 days, you're really looking at high risk of infection. I mean, really high risk of infection. They have to be put in by a physician or an anesthesiologist. CRNAs can also put these in. They are usually done in surgery, but they can be done at the bedside, so you may be assisting with these as well. Again, the tip of this catheter ends in the vena cava. We place them in Trendelenburg position for insertion. So I want you to think about that. Why? First of all, I hope you know what Trendelenburg position is. But why would you place a patient in Trendelenburg for insertion of a catheter? And whenever we insert these, we usually put them into the IJ, or internal jugular, and that is the preferred place for them. Subclavian and femoral. And during codes, I've seen them placed in the femoral because they couldn't get into the IJ or subclavian very easily. So I think at codes about the only time I've ever seen a femoral placed. They usually put them in the IJ or the subclavian. They're greater than 8 centimeters in length, and you can have single, double, triple, quadruple lumens. It is a sterile procedure, just like a surgical procedure. It's sterile when you put it in. But let's go back to this Trendelenburg for a minute and get your brains going and tell me why you would want to put a patient in Trendelenburg before you inserted this line. Okay, I hope that you paused this and you thought about this and you just didn't wait for the answer. And I'm hoping that what you thought about is this. When we have a patient in Trendelenburg position, the position is what? Head down, feet up. So if I'm going to insert this big bore needle into a person's neck, first of all, why are they going to need this? In a trauma situation or a surgery situation, most of the time the patients who need these lines are a little bit dehydrated. So if we put them, we stand them on their head, so to speak, then that's going to do what? Gravity's going to take over, and that's going to push more blood up into that vein. So it's going to make it a little bit juicier, a little bit easier to get into. So that is a big reason that we put them in Trendelenburg. But there is another reason, and the other reason is it decreases the risk for air embolism. And we talked about air embolism with complications, and so you understand what that is. And so if we can put them at that angle, it's going to decrease the risk of an air embolism getting in there. And I know you guys figured that out before I even said. Okay, so complications, they are at high risk for infection. And we already talked about this a little bit when we talked about the PICC. So why was the PICC at a lower risk? Due to the area that it's placed. So the high risk for infection of the non-tunneled, and actually the non-tunneled has the highest risk of infection of all central lines, and that's related to the oily skin that's on your neck and your upper chest, more types and amount of microbes, and the location of that dressing. And also this would also be true for the femoral as well. and that's where we would also put a non-tunneled. Also the risk for pneumothorax and a hemothorax. Now obviously if we're putting in a femoral, we don't have that risk, but in the neck and the chest, the subclavian and the IJ, we have a huge risk for collapsing a lung or having blood escape into the pleural space. The picture on this slide just shows you what an IJ would look like. The heart's there, shows the subclavian and the IJ coming out, and how the IJ leads up, and that is actually where those lines are. Contraindications in a non-tunneled. We just said that we have to put them in Trendelenburg position. So if a patient can't be in Trendelenburg position unless it's an emergent do or die situation, what you're going to do really isn't going to make a difference type situation, you're always going to put them in Trendelenburg. And why would we worry about that? Well, if we can't put them in Trendelenburg, what would be reasons for that? A patient who has respiratory conditions. If you stand me on my head, am I going to have more difficulty breathing than if I were sitting upright? Well, of course. And some patients can't lay flat, much less stand on their head. So if we have a patient who has serious respiratory conditions, then we would need to reconsider. And also increased ICP or intracranial pressure, because again, if I have increased pressure, intracranial pressure, and you stand me on my head, that's just going to make it worse. So we really have to think about what's going on with our patient, and are they at risk for these things before we put the central line in. And a lot of times you have to let the physicians know, hey, this is going on with the patient. I don't know if they're going to be able to withstand this. We might need to look at something else. Also, because the lines are placed in the neck and chest, if you had trauma surgery, radiation, anything going on with those areas, then that would obviously be a contraindication for that. The next one we're going to talk about is called a tunneled catheter. It's intended for long-term use. We put it into the IJ. We can do EJs, we can do femorals, and we can do subclavian. Subclavian is what we normally choose for a tunneled cath. Alright, again, this one is the same as the non-tunneled with the greater than 8 centimeters, and that's going to depend on the patient's size again. I think your book might say that they're usually greater than 90 centimeters, but not for sure on that number there. Physician will place these. They can be under local or general anesthesia. They're usually done in surgery. They are done in surgery. These are not done at the bedside. This is a surgical procedure. It's tunneled into the subcutaneous tissue under the skin, usually about 3 to 6 inches. Okay. The distal tip, again, is in the superior vena cava. Initially, these are placed in the skin. They cut a little incision in the subcutaneous tissue there in your chest, and then it's slid in about 3 inches or so, and then it's inserted into the subclavian, and then it follows the subclavian into the vena cava. So they're initially sutured in place, but after 7 to 14 days, we can actually take those sutures out. There is actually this little cuff around the catheter itself, and that's why we inserted that 3 to 6 inches into the tissue before it goes into the vein, because that little cuff, we call it a Dacron cuff, it has some anti-infective properties on it, like it's antibiotic coated or something, and that sticks into the subcutaneous tissue. It attaches to it, and then it starts to heal and scars up, and so that's what holds that catheter into place in the subcutaneous tissue. It helps to stabilize that catheter, and it also minimizes the risk of infection. So that's how those catheters are put in. Alright, so this slide just tells you what I just said. The tunnel is put in the subcutaneous tissue, and then initially it's sutured in place. It's removed after 7 to 14 days, and that Dacron cuff is what decreases your risk for infection. You do not have to have a dressing on it once the site has healed. Okay, and again, this has less risk of infection than a non-tunneled, and that's due to that Dacron cuff that's placed in the subcutaneous tissue there. These are examples of tunneled catheters that you may hear their names: Hickman, a Groshon, and a Broviac. The one on the left there, the Hickman, that's what you'll see a lot of times in the hospital. The middle one, the Groshon, the reason that I have the pictures of this is because a Groshon is special in the fact that it has a valve at the tip of the catheter, which makes it unnecessary to leave heparin in it. The central lines we do flush with heparin instead of just saline. We'll flush them with heparin, but when you have a Groshong, you actually can just flush with saline. And this picture here kind of shows you what the tip of it is, and it's a valve. So when you push medications open, that valve opens and lets it, or push medications through, that valve will open and let it in, and then it immediately seals back off, and the same whenever you're drawing it. So clamping is not required, and the valve is closed except for whenever we're using it. So it's a pretty cool thing. They have those in the ICUs and CTUs. You'll see those whenever you do your rounding up there. And then the last one I'm just going to mention, we don't focus on pediatric in this class, but this is called a Broviac, and it's just a smaller size, and it's what we use on little kids. Okay, so management of the tunneled and the non-tunneled. The catheter is capped at all times. Now, all IVs should be capped at all times, but it's important that these central lines are capped at all times. If your catheter leaks or it's clotted, do not use it. Okay, if it's leaking, it's pretty much, you're going to have to get it out. That's just the way it is. You're going to have to remove it. If it's clotting, or if it's clotted off, then you usually have a declotting protocol, and you'll have to refer to that. They usually use Alteplase or Activase or something like that they use in order to declot the line. It takes some time to do that, but it's pretty amazing when you do it to see how well it works. You want to make sure that you're protecting the lines when they're in the shower, and you want to monitor for all complications. We've talked about infection. We know that a thrombus can occur. You want to make sure that you're watching for catheter migration. Is the catheter torn? Is it leaking? Making sure that it's not sheared off. And air embolus. And I know that we've talked about air embolus a lot of times, but it's a big thing with central lines. You really have to watch. I mean, you're talking about a big catheter going in, and so we have to make sure that air is not getting into our vascular system. And if you do have an air embolus, what kind of things are you going to see? And we touched on this with complications, but we're going to see tachycardia, chest pain, possibly confusion. So you want to make sure that you're really. And then last, we're going to talk about an implanted port. It's a port that's attached to a catheter that is implanted subcutaneously. Again, it dwells in the superior vena cava. The proximal end is implanted in the subcutaneous tissue there in the upper chest wall. So what they do is make a little incision there, and they insert this port. And I think on the next slide I have a picture of what this looks like for you, so you'll get a visual. After 24 hours, no dressing is needed. So we only have that dressing on initially for any oozing or bleeding, but after that you shouldn't have to have a dressing on it. The preferred site for an implanted port is subclavian. We do use the IJ if needed, but the preferred site is subclavian. The parts of the port, the reservoir and the septum, and you can see on here where this picture that I have over here that shows you the reservoir and the septum. The reservoir is that purple piece on that picture, and then the septum is where that needle is going straight down into, and it's a self-sealing silicone. It can withstand around 2,000 needle punctures. So you stick it in and you pull it out, and it just seals itself right back up. It's pretty amazing actually how they work. A Huber needle, it's a special needle that we use to access the port, and this also shows you a picture. It's a non-coring needle, meaning that when it goes in, whenever you poke in a big bore needle like that and it were to go in, it would core part of that out, but this needle does not do that. We insert it at a 90-degree angle, so it goes straight in, and you can see how this needle goes straight in there. And then if you look at that little picture over to the right, it tells you, you see the septum where the needle has gone straight in, and the skin line where it's underneath the skin. Okay, and then how the catheter feeds into your blood vessel. So look at that little picture there, and it kind of shows you how this port would work. You palpate it to insert it. So when it's under the skin, if you can look at this little purple device here on your picture, you can see that there's 3 little knobs on the top of that septum. And when you are palpating the skin, you actually can feel those 3 little knobs underneath the skin. So you actually would palpate that and feel that. You'd place your fingers over it, kind of in a V position, and I can show you this better in class whenever you see me. But you place them over it, and then you just take that Huber needle and stick it right down between your fingers into that septum. Okay, there's minimal discomfort with the patient. They barely even know they're being stuck, if they know at all. I always say I wish God had made us all with an implantable port, because how wonderful would it be to never have to be stuck again? Because you don't even. This is not even like a bee sting. I mean, it's just you barely even feel it. It's just like a touch. This picture right here for the implanted, this is actually what it looks like under the skin. Now, if you have someone who has a little bit more adipose tissue on them, a little bit more fat under there, you may not even be able to see it that much. So this is what it'll look like, and I'm sure some of you have seen this in the hospital setting. This is the central line that has the lowest risk of infection, and hopefully you can see why, because it's under the skin, and only when we access it would there even be a risk of infection. It is less body image disturbance, because now you don't have this big line hanging out of you, okay? Less interference with activities, and again, that's for the same reason. And also, you just have minimal flushing with this. Ports need to be flushed once every 30 days unless they are accessed. And if the Huber needle is in and it's accessed, then you would just follow protocol for that. And they usually flush central lines every 8 hours in the hospital setting. Complications for this type of port is the same as a tunnel catheter. But again, know that the risks, like for infection, are much less with this type of catheter. Okay, so let's talk about nursing care for all central lines. So, again, I've told you this already. You have to have x-ray confirmation before you can use it, so that we know that that catheter tip is where it's supposed to be. Okay, if for any reason that your patient has pain or an unusual sensation, then you would want to go ahead and get another x-ray just to make sure that that thing hasn't dislodged. We want to make sure that we're assessing site, that we are assessing the dressing, and that obviously we're documenting all of this. We're looking for signs and symptoms of infection. We're making sure that we're keeping that dressing in the site clean and dry. If your dressing has loose corners on it, that means it has to be changed, even if it's not time. So you've got to go ahead and do a sterile dressing change on that. And if it had sutures in it, like the tunneled initially has sutures, so you would want to address that if they had them, but you're not going to see sutures all. When we talk about central line removal, the only time that we would remove it is if there was an infection and we had to take it out, or the patient was done with it, and we would have a physician order to remove it at that time. If you are removing a line, now obviously you're not going to remove a tunneled or a port. Those are surgical removals. They have to go to surgery to do that. But you can remove non-tunneled and PICCs. So if you're removing those and you meet resistance, don't force it. So think about that. Why? Why do you not want to force the line out? I hope that you answered my why question and that you came back with this. If you apply force, you could actually cause the catheter to break or shear off, and then it could embolize to the heart and the lungs, and that would be bad. So if you feel resistance, then definitely do not force it. Okay. Remove sutures if they're present. Again, you may or may not see those IJs that are put in, those non-tunnels. They do have sutures in them to hold them in until we take those out. And I already told you that the tunnels and ports are surgical removal. We want to make sure that we hold our breath whenever we remove them. The PICC lines, not so much. The IJs are the non-tunneled. Those are the ones that we want to have our patient hold our breath. So think about that. If I have a non-tunneled in my IJ, internal jugular, it's in my neck, why would I tell my patient to hold their breath? I hope that you paused this and you figured out why. Because that is a large hole that we are pulling a large bore needle out of. And if they don't hold their breath and they take a big breath in, whenever we're pulling that out, they could actually, the pressure in there could actually allow air to enter into the vascular space. Then we have another air embolism that we have to deal with. So we want to make sure that when we remove a central line, that the patient is holding their breath. When we remove them, we want to hold pressure for about 3 to 5 minutes, and we do not use alcohol pads. Why do we not use alcohol pads? I think that you probably learned this in pharmacology, and that's because the alcohol may interfere with the clotting, and so we may actually have more bleeding. And then we would cover that with a sterile dressing, and normally it's an occlusive sterile dressing, and that's normally on for about 24 hours, and you can remove that. Okay, when we flush a central line, we always make sure we aspirate for blood, and you guys know that from just a peripheral, that we always make sure we aspirate. We always want to make sure that we use slow, gentle pressure on the syringe, and actually with the central line, we use like a pulsating movement. So you just kind of push with your thumb in a pulsating movement to push that in. If we meet resistance, we want to stop. We never want to force. What are you going to do? If you can't get anything in, then you would want to try to reposition, because sometimes those lines are positional. Might be up against some structure in the body that was kinking it or moving it, so we would reposition and try again. You may have to implement the declotting protocol, and you definitely want to let the physician know that it's not flushing. We usually flush those with heparin, and again, I talked to you about the Groshong, so you wouldn't need that with that valve, but central lines are normally flushed with heparin. And because they are flushed with heparin, PTT, as we already know, is the lab that we use for heparin. So if we are doing blood draws, say your patient is on a heparin drip, then you wouldn't want to do a blood draw from the same line that you're infusing heparin, because that is going infused with heparin, because that's going to affect your PTT. Remember, whenever you are flushing, that you use the acronym SASH, and that stands for saline, administer, saline, and heparin. So remember that SASH, and that's what you do whenever you're flushing central lines. Dressing changes for central lines, we would remove the old dressing just with regular gloves, and then we would apply sterile gloves to do the new dressing, because it is a sterile dressing change. And you guys all know about sterile wound care and how you would do a half moon around the site whenever you're cleaning that. You want to make sure that you wear a mask, and you also want to make sure that you place a biopatch. That is now best practice, to place a biopatch. This picture on your slide shows the picture of a biopatch, and it's that little blue disc. It actually has a little slit down one side, and it'll just slide right on around that line, and you'll change that every time that you change central line. And there's actually antimicrobials on the bottom side of that disc, and it'll help prevent infection. So that's why we use those. Rationale for central line versus peripheral. Why would we choose to do one versus the other? Well, it's usually determined by the length of infusion. Am I going to give them this drug for 2 days or for 2 months? So that would determine if I needed a central line or not. The type of medication, is it caustic to the vessel, or is it something that's not going to be very detrimental to the vessel if I put it in? And then again, your patient's health status. They may have so poor venous access, our only option is a central line. When we are looking at placement, for example, we look at their diagnosis, we look at their condition. We would find that they had poor nutritional status and they needed TPN. So reasons that we would have to use this: they can't meet their nutritional needs. They have a non-functional GI tract. Cancer patients who have abdominal cancer or cancers in that region, we may need to put in a central line for TPNs, because they can't eat regularly, so we would want to put something like that in. Patients who are comatose, obviously they can't get nutrition, and we would want to go ahead and put a line in. And then if they needed high calories due to illness or injury, something that we would need to use for TPN. So you're going to have to look at your patient diagnosis, their condition, and their need for a central line. And this is just an example of why we may do this with the patient. The type of care that's required, dialysis catheter is considered a central line. You couldn't do dialysis any other way. So you're going to have to look at the type of care that's required. They may have limited venous access, irritating drugs that are going on. Patient may request it. Now, I'm not going to tell you that all times they're going to get that, because that's a more invasive procedure, but I have had patients come in and say, they can never get a line in me, and I've had to have a pick the entire time. So I would discuss that with the physician before I ever stuck them, and then we would decide what was the best route to go. And then again, long-term intermittent infusions, and that would be like outpatient antibiotic therapy that we've already covered. Informed consent. This is an invasive procedure, so central lines must have informed consent. Patient has to know what they're getting themselves into. So it's your responsible as the nurse to make sure that they're competent and to ensure competency, and that they're able to make an informed decision to get this line put in. And then, of course, patient teaching would be about the device and any treatment that you're going to give them through the device. Documentation. You have to document your insertion. You have to document while it's in there, or to maintain, and then you also have to document on removal. So whenever you do insertion, you want to do a timeout. You want to make sure that you document the site. You want to document patient tolerance, the length of the catheter when it goes in. How long was it? Perhaps let's look at a PICC line. Whenever they insert those PICC lines, it is documented how long, how many centimeters that was inserted into the patient, so that we can, when we remove it, we can refer back to that to make sure that the entire length of the catheter was removed. During maintenance of it, again, you're always assessing your site. Your dressing changes have to be documented, flushing. If there's any problems with it while it's going in, you have to document that. And then removal, positioning, site assessment, always ever important that that tip is intact. And then a lot of times with central lines, especially if we're concerned that there's an infection, then we would send it for culture, and you would obviously document that you did that. And I believe that is the end of your lecture on central lines.